Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. New Hampshire.
Okay.
Yeah.
Well, I wore my Kansas City shirt to assert dominance over you guys and your Philadelphia Eagles. Your EGSLES.
EG, yeah. That was not a good look. Talk about making a meme like pre-delivered for the people. But
I do feel bad for her,
my
though.
son likes the Chiefs.
Yeah, you were telling me that.
Yeah.
And Elena was just wanting them to beat the Bills.
Yeah, Elena wanted them to beat the Bills because Elena was, I already hit records, people are listening. Elena and her 8th grade boyfriend broke up and he dumped her, and his family are diehard Buffalo Bills fans. So she really could care less about football. What?
Is she still in 8th grade?
Yeah.
Oh, okay. I knew that she and my middle were just a few months apart, and Emmanuel is a freshman this year, so I assumed Elena was as well.
Yeah. Oh, before we start, speaking of Elena, I'm going to tell a funny story about Elena because she's definitely my daughter. They go to a private school. There's upper, middle, lower school. They're all in separate buildings. The lower school had this week a pre-planned shelter-in-place severe weather drill. So my daughter, Elena, in 8th grade, is in her French class in the middle school building, and another teacher came running into the French room and showed the teacher an alert message on her phone and said, "Look," and they real quickly slammed the door shut, locked it, put the blinds down, turned the lights off. The one teacher was panicking, told the kids to get under the desks, and nobody made noise. She handed out golf clubs to some of the students and said that they got an alert, there's an intruder in the building. So Elena said, like, a couple kids started crying, one kid started hyperventilating, and like they're trying to like suppress like crying because they didn't want to make noise because they thought there was an active shooter in the building. And Elena said after like 2 minutes of her being huddled up on the ground, she realized something was amiss and that this didn't add up. And she said she just went, "So who do you guys think are going to win the Grammys?"
Oh, dude, I read that as though she was asking which one of them was going to win the Grammy for acting and being like scared.
Oh, no. She said, I realized that they had fucked this drill up and that this was a drill. This was not an active shooter.
That's why I wrote back and I was like, that's your kid. Like,
yeah, she said they're just like huddled under the desk, and she went, "So who do you think's going to win a Grammy?"
That's awesome.
Oh, man.
Trying to make light of it.
So I'm here with all-star panel today. Wes Nelson, firefighter, paramedic, training lieutenant. Did I get your rank correct?
Yeah.
From New England, and you all know Gwenny, Nurse Gwenny. Director of Education at Impact EMS and author of the book But Why? CFRN FPC test prep question book. So I went through and I polled the listeners for questions, and I put together this giant 2-page list of questions. Clearly, we're not going to get to all of them, but the way we're going to do things, we're just going to round robin. Each person picks a question they want to ask and pose it to the group, and we'll talk about it. So before we get started, does anybody have anything they want to say?
Not at all.
All right. Well, ladies first. Gwenny.
Just pick one off the list. I didn't print it out. I went through them all and answered them in my head. And my other computer is busy right now. I can't even make eye contact with that computer because it's uploading a video of you. That's 2 hours long. And if I disrupt it,
it's a work video. It's not a pleasure video I sent to Gwenny.
That's a good disclaimer.
Yeah.
As if it was necessary.
All right, Wes, pick a question.
All right, let's just start at the first one with, have you ever dealt with imposter syndrome or a lack of confidence in your own abilities as a provider?
All the time. I think the only thing, well, clearly I'm more confident 23 years into my career and now going into 18 as a paramedic. So clearly I am more confident and I'm more grounded. But hell yeah, I get imposter syndrome. Absolutely. I think the big difference is that I now realize that it is what it is and that it's normal. And a healthy dose of imposter syndrome, I think, is a good thing.
I think it's terribly alarming when someone has no fear whatsoever. You know, on the Dunning-Kruger effect, you get a little bit of knowledge and experience and the confidence goes way up. And that's all of us, like the day we graduated nursing or medic school. Like we thought we knew it all. And then, you know, a week in actual practice, it falls. And then if you look at that graph, it slowly and steadily goes up as you get more actual knowledge and experience. Then your confidence begins to climb back up. But I don't believe that that progress is linear. I think it's, you know, it ebbs and flows. You know, you might have a run of patients where you just like nail it. Your clinical acumen was just spot on every single time. And like I had to shift recently where I was working kind of the medium acuity portion of the ER. And I had a patient that I just knew it in my soul. She had an ovarian torsion, and the mid-level that was working that day that would normally see those patients, I had had an ovarian torsion with her a couple months ago, and she dropped the ball and she wouldn't listen to me. And this patient sat in the ER for 4.5 hours before she went to emergent surgery. Yeah. And as someone who has had 2 ovarian torsions, like you don't sit on that.
I was going to ask, were you that patient that's
No,
at the
I was not the
ER?
patient, but
Okay.
I have a really low threshold for like, if I even think anybody has one, I start moving really quickly because I know how that feels and it's terrible. But anyway, the one I had a few months ago, I knew it right away. And I tried to tell the mid-level, like, this is a torsion. We need to act really fast. She dragged her feet. She did all kinds of crap. And 4.5 hours later, the patient went to surgery and the OBGYN ripped me a brand new asshole and said, why the hell has this patient been down here 4.5 hours? I said, you're preaching to the choir. I've been trying to get something done on this patient this whole time. So anyway, a couple weeks ago, I had another patient that I just knew it in my heart that she, like with my whole chest, I knew this patient had an ovarian torsion. It was the same mid-level. And I was like, no, we're not doing this again. So I go to the other side of the ER. I asked the physician, he's a friend of mine. And I said, hey, this patient in bed 18, I know it. I know she's got a torsion. Last time I had one with this provider, it took forever. Can you please see this patient and get stuff going? He orders pain meds. He orders the ultrasound. He orders the all kinds of stuff. And we get it done right away. And it comes back, she just had a really big cyst. And after that, I was like, I don't know anything. I don't know what anybody has. Like, I'm stupid. And so like, I've been feeling really like, I'm not going to speak up to the doctors. I'm just going to wait for their orders. And my confidence is low. And I feel like it goes like that throughout our entire career.
My dad tells this. He told the story the one time he came on the podcast that his message was, he was talking about stroke and he said, you never know what you're going to find in a CT scanner. But he was talking about this patient that he got consulted on, came in with acute dizziness. And he said all the clinical findings did not correlate with stroke. He said he was kind of, he didn't say it because he's a humble guy. He's unlike me. He's a humble, nice person. But I could tell through dad speak that what he was trying to say was that he was pissed off that the ER consulted him and that he thought it was kind of like, you can't handle this. You need me to tell you that this isn't a stroke. And he said that he's checking this patient out and everything told him this is vertigo. This isn't a stroke. Classic case of vertigo. And he said, but you know, just to be safe, sent the patient for imaging, and he said, oh, she had a stroke. All right. So you're right, Gwenny. It's everybody. It's not just us. I mean, here he is, an attending neurology professor, and here he is, like, getting a little dose of humble pie.
It's not fun.
Yeah. One of my early mentors, once I was in paramedic school, I had actually probably finished medic school at this point and had been a licensed paramedic, and I was just doing calls with him, and I'm like, well, you know, I studied all the different ologies, and this person had like this symptom and that symptom, but those two don't add up. Like, what page on the textbook was this patient? And he was like, the patients don't read the same textbook. You can't apply everything you learn in a textbook to them, and it just takes a lot of time. And what I tell people is not experience, but experiences. Where you could be a medic or a nurse for 20 years in a low volume system with very few experiences to learn from. But when you get into one of those higher volume ERs or pre-hospital settings or flight programs, you gain more experiences. And as long as you have meaningful reflection from them, it's what helps you grow. But to the point of imposter syndrome, I'm in the same boat as you guys. Yeah, I definitely get it sometimes. There's days that I feel like I'm on top of it and 3 steps ahead of the patient. And then there's days where I have no idea what's going on and I'm just trying to work on my objective findings.
I really like that. Experiences over
Yes,
chronological experience.
exactly. Yeah. Yep. I like to preach that one pretty heavily.
That's good.
All right. Cool. I will pose a question to the group. How do you help steer your EMT partner to not get complacent and avoid ego while they go to paramedic school?
I feel like
Easy.
this is
Go
a
ahead,
very
Wes.
good
Sorry.
piggyback question from the first one. Show them what the Dunning-Kruger curve looks like, and they need external calibration to realize that while they are the most intelligent person in the room because they are deeper in the, or rather closer to the textbook than we are, that would be kind of the difference between knowledge and wisdom. And they have a lot of knowledge, but the wisdom is not instilled yet, and that it takes time. And unfortunately, they will learn weeks, like Gwenny said, or months into their EMS career as a paramedic, that it is quite humbling. And the paramedic or the patients don't read the same textbook as you. So
I think the answer to this one is super easy. Model the behavior that you want to see. It's just like parenting, right? If you don't want your kid to turn out as a selfish little brat, then don't be a selfish brat yourself and model the behaviors that you want to see. And so just because we are done with our formal education doesn't mean that we're done continuing to learn. And if I think that culture is contagious. I couldn't think of the word. It was out of my head. It's contagious. And so if we can practice the continued learning, the humble pie, the making sure we're checking ourselves, I think that we'll see that out of our colleagues as well.
Mike, minus a slap in the face, what do you got for him?
Well, I tend to be Mr. Negativity. You were talking about how they may be the most knowledgeable in the room. People are going to roast me for not being a nice person, but when I am an FTO and I get a student like this, I like to test whether they actually do know the stuff, and I will quiz them on knowledge that they should know to make sure they're not the smartest, to make sure that they have mastered the material that they're supposed to know. And if they don't know the material that they are, I don't expect the student to tell me how water is reabsorbed at the loop of Henley. I'm not that much of a prick, but I will expect them to know the basics. And if they don't know the basics, I will, they won't be so egotistical when they leave that shift. But I guess if they're your partner, I guess let them know, like, hey, you're in medic school. That's great. But your job right now is an EMT. Like, you're not supposed to be a paramedic. We are here to be EMTs. And when I was in paramedic school, I was working full-time as an EMT, and I had good friends of mine were the paramedics that would respond on calls with me. And there were a couple times they were like, hey, dude, you're not the fucking paramedic on this call. You're still the EMT. And I was like, point taken.
That's pretty valuable. I think I could use that one at one point. But what about the person who is at the top of their class and black and white knows the textbook and knows the material? I think the thing to remind them is that the difference between the textbook and a call is EKGs on your 12 lead or on your monitor going down the road don't look the same way they do in the book. It's not static cardiology. Everything is different when you're actually on a call, and you're taking that foundational knowledge, which is black and white, and applying it to a very gray situation. And sometimes you nail it and sometimes you don't. But practicing is much different than sitting in a classroom.
Yeah.
I think this question was a little unclear because not get complacent and avoid ego. I think those are two completely different things. I don't think they're necessarily related.
That's a really good point. I'd be interested the root of the question with complacency with somebody in paramedic school. Typically I think of complacency as coming after you've finished whatever course and you have that certification now, and you kind of get in the groove of complacency.
Yes,
and
exactly.
That's later on where ego of doing well in paramedic school and having great grades and whatever. I agree. These are two different kind of scenarios.
My experience with EMTs who are going to paramedic school that are still working as EMTs can be that they're a little overzealous and they overthink too much, not complacent. So they'll call for an ALS rendezvous on some lowball random stable, like totally stable patient. They'll be like, I was thinking maybe they have a PE that wasn't, they could have a PE in the distal branch of this one part of the pulmonary artery, or, maybe that could have traveled off and broken and it's in their right MCA now. And it's like, hey, you're thinking too much. Like, you good with this? See ya. I'm clearing.
Yeah.
Like, that is one thing though to ask. If you have somebody who's trying to flex their knowledge to you on a call, I'm all about knowledge. I hate know nothings. But at the same time, ask that person, okay, you're like nerding out on this. Does this really matter right now? Does it? If it does matter, please teach it to me. But if you're just showing off and you're trying to use this as a flex to showcase your knowledge, then let's just put the patient on a stretcher and take them to the hospital.
Yep.
Agreed.
I like that.
All right.
One stuck out to me. It might be on the second page.
There were some good ones in this.
There was some pretty good questions here. It was very thought provoking. So the one that stuck out with me, because I lived this one for a bit, was how do you stay positive and keep the passion while on a stint of being a white cloud? The reason that one stuck with me is there have been multiple times in my career, just as a paramedic, where I was stuck in a white cloud. So I have my own experience I want to share with you guys, but I want to hear what you have first.
I liked that question as well. And I absolutely agree that complacency when you're on a white cloud is cumulative. If you have one flightless shift, you're like, I got a little bored. I went for like 6 different walks to keep busy and did 3 different workouts, but by the second time and third time, and then you're watching shows and you haven't done any studying, you haven't gotten out the airway heads. I find that the kind of laziness when you're in a white cloud is cumulative, and then you get whipped out of it. So it's just a matter of keeping your headspace healthy and holding yourself accountable, and nobody else is responsible for that other than you. And so it just is up to what are you willing to do to make yourself uncomfortable to make sure you're ready to go, even if you're in a stint of a whole bunch of flightless shifts, which happens a lot in winter where I live. We get a lot of weather that we can't fly a lot during the winter. So when you're on rotor, you'll be watching a lot of Netflix or doing a lot of reading and studying. Depends on what your motivation is.
Mm-hmm.
I will, because I've been there too, where I have gotten complacent from a whole stint of doing nothing, and then I get some hot job and I'm kind of caught with my pants down because I've been complacent, unfamiliar with where stuff is in the bag, even though I've been there forever. You're just, when you get cognitively taxed like that, I mean, we don't need to go into a discussion of human factors, just not, you need to be prepared to be able to spring into action when you're cognitively taxed. So what I will do, you could tell all the cookie cutter stuff, all the podcast and social media snippet stuff of use every day to prepare and, find a project, find a passion project and teach yourself something new every day. But what I will do is when I feel complacent and when I'm doing nothing, I don't make it an extravagant thing. I will take 1 to 5 minutes and I will think of something random. I'll think of, you know what? I haven't had a pediatric anaphylaxis call in a while. And I'll pull out the protocol and I'll read that. Or I'll walk out to the medic unit and I'll say, I have not put my hands on the cricothyrotomy kit in a year. Maybe I should go through the kit and just touch the stuff, familiarize myself with what's in the kit. Or I did this the other day at the helicopter. I said, I have not looked at the Flowland setup in a year and a half. I'm going to go review that in my brain real quick or watch a 5-minute YouTube video on something like that. So I have found that to be invaluable because just those little 1 to 5 minute self-training sessions are invaluable at keeping your brain prepared.
Yeah,
I think
absolutely.
those are good ideas. And I guess I looked into the question differently. I saw the white cloud statement, and the way that I've used that in the past is not because my volume has decreased, but the calls that I've gone on have been very lowball calls for a long stretch of time.
True that. That's where I am right now.
So that's where I was, when I saw this question, I was like, man, I've gone through this dozens of times through my career of being an EMT. I got my EMT in 2007. and then kind of went through from there. But it wasn't really until I got my medic license and really wanted to do all these skills and things that we could do and wasn't able to because of these calls that I started changing the game and basically playing out the scenario differently. So when I was on a call for belly pain or something and we were riding to the hospital for 10 minutes, I would think about what are the 3 things that this could turn into that would kill the patient within the next 5 minutes, and how would I treat each one of those. So it would, like kind of what you guys were saying, is like keep my mind sharp on the protocol and the medications, dosing and routing, but kind of pre-plan for if a patient decompensates. And granted, you would know that this patient isn't going to, but it was preparing you for that next one that's questionable, like that abdominal pain that has the tearing sensation posteriorly, whose vitals are initially hypertensive. It's like you kind of start getting ahead of the ball. And one of my old medical directors used to say that is always come up with your plan A, B, and C for 3 different differential diagnoses. So even though you don't have something clear, cut and clear in EMS yet, where you don't, Mike, you'll love this, where we don't have a diagnosis, but we have differentials, pick 3 of them that are going to kill the patient first, and then have a plan A, B, and C for each one of those, so you're not caught off guard. And that was my way to get through being in that white cloud. And I still use this when I'm in my kind of just flying strokes and STEMIs, or if I'm on the ground doing ground EMS, like what's going to kill the patient next. That was my way to deal with it.
True that. Good. All right, let's do a clinical question.
All right.
Gwenny, I think you're going to have some input in this because this is kind of your wheelhouse. Is pre-hospital point of care VBG worth anything?
Yeah, sure. So ground or flight, transport altogether, it really depends on what your transport times are. So where I fly at, we fly a lot of patients to St. Louis. And for us, depending on winds, that could be an hour and a half each way. Or if we're on the ground truck, because we do ground and rotor, that's a 4 to 5 hour trip by ground. And so that's going to be something we may need to do a VBG. If this is a super sick patient and I'm unsure of my ventilatory approach with this patient and they were in a severe acidosis and I'm trying to compensate for that, I think drawing a VBG could be helpful. But if you're just flying patients because you live in a super urban area, like in Illinois, where I grew up and lived for a long time, there were a ton of helicopters because it's a 3-minute flight to St. Louis. Or if you're trying to get across the one bridge that goes through there, you might be looking at an hour and a half. So if you're doing short flights, it doesn't make sense at all. And it depends on how sick your patients are. So I think it could have some utility, especially in these like rural places that are transporting for hours. That's it. I'm just beating a dead horse.
I think I'm going to go with no, because I think it's going to very much depend on what your local protocols say. And if there's no protocol saying that you can fix somebody's potassium or calcium, or if you're limited in what you can do for a diabetic emergency, unless the protocols align with the ability to use a VBG for correction, I don't see it. I mean, it would probably be easy enough to make a ventilator guideline for each state that says if you have an ABG and you know your bicarb is this, then do this. I don't see it working pre-hospital outside of critical care, obviously.
I love something you said that I think could be extended to a lot of our diagnostic and interventions, is that I'm not a gigantic fan of Pocus. I know I might be burned at the stake for that, but I've never worked for a service who has Pocus. But I have yet to be convinced of the utility of Pocus pre-hospital, because I don't see how it's going to change our interventions. If it's not going to guide my clinical decision-making, then why would I do it? So a lot of Rick and I have these conversations from time to time because he loves Pocus. And he's like, well, I might be able to see if, there's a corneal detachment if it's an eye injury. And I'm like, okay, and? Like, how is that going to change? They said, well, I might be able to see if there's, blood in the belly. Okay, well, I can also see if the patient is actively hemorrhaging based on their shock index, what the patient looks like, what their mechanism is. And it's not going to change what I do. I can't perform surgery in the helicopter. That's not within my scope. So it's not going to change what I do. So I really love what you said there, Wes, is that unless there are protocols that allow us to use that information, it's absolutely pointless. 100% agree.
Yep.
Can I tell you what changed my mind about Pocus?
Yes.
And I'm with both of you. I'm totally with both of you. Like, we are probably getting Pocus within the next year. at my ground job. And fast exam and trauma, it's all I hear about, fast exam trauma. I could give a fuck about a fast exam because we are taking a trauma to a level 1 trauma center. That's our only option for a trauma center in my district is Christiana Hospital, the big ass level 1 trauma center. So there is going to be at least 12 or 13 residents, all with Pocus probes in their hand when I roll in the door. Like, I'm going to the trauma center anyway. It doesn't matter whether I identify a positive fast or not. Fluid responsiveness, yes, you can make an argument for it. I don't think it's perfect. I think you're going to get people going down rabbit holes, overthinking it, blah, blah, blah. But there's a guy, credit to him. His name is Wes Rogers. I hope I'm getting that correct, from Texas, I believe. He sent me a very cogent argument on lung ultrasound. You can really clearly and easily tell congestive heart failure through a lung ultrasound. And I think that is where the money is. Now, I've had Josh from Alert Medic 1. He came on and we talked a lot about low flow states. Is this patient in cardiac arrest or are they just in a low flow state? I think there's practicality there for sure. Pronouncement of death, because I can't tell you how many times we get some med control physician who doesn't know jack shit about EMS or pre-hospital care that answers the phone when we call to terminate an arrest. And they say, oh no, but we transport this dead body that we're beating on to the hospital just so they can put a probe on their chest and go, oh, yep, they're dead. But the lung ultrasound is what really changed my mind. I had a woman the other day. She is crashing. She's got a pulse ox of 65%. She's fat. She's got swollen ankles. She's wheezing, rhonchi. I thought I heard a little bit of crackles. She's got a COPD history, and she's got this enormously high blood pressure. And I was like, what the hell is going on with her? Do I treat her for CHF or do I treat her for a nuclear COPD exacerbation? Because if she's got CHF, I don't want to be giving her a bunch of beta agonism. Like,
because
now
she
I know.
can flash.
Shut the fuck up. But I also don't want to needlessly be giving her mag, terbutaline, all the things if her problem is CHF. And I was thinking, you know what? Pocus would be really useful right now.
Yeah, I'm open to changing my mind about Pocus. I just haven't had anybody convince me yet.
I was a big naysayer.
The Hocus Pocus episode. Yeah, exactly. So on the Hocus Pocus episode, I made it very clear I was against it. And at the time I was, and now I've kind of, like you, Mike, I've pivoted where my flight job rolled it out in a fantastic way. It was just initial education on what ultrasound is and what it looks like and the terminology associated with it and what is normal and what is not normal. And we started with just peripheral IVs, which, my God, to save some people that are conscious that you need fluid resuscitation, that you don't want to give an IO, but sometimes that's your only option. Now we have another option that's far less painful. It is super easy. We then moved on to lung assessments and lung scans. And I can get there. I agree with it. I don't think that the Pocus changes your decision-making process. It just confirms it. And that's kind of a line from Justin from that Hocus Pocus episode. But on the side of CHF versus COPD, we've been making our differential on that for years based on the clinical presentation, your lung sounds, your SpO2, your blood pressures, and knowing that you're not going to put them in a flash pulmonary edema. Like, I don't think it changes that much on that side of things. I like it for confirming that lines are in place where they're supposed to be. And then I think, yeah, pre-hospital, the biggest use of Pocus is going to be in that termination of efforts, outside of peripheral line placement. The termination of efforts, like, is there any sort of cardiac workup? The next module we're going to do is cardiac scans, and that's going to take a tremendous amount of time for me to learn personally. But yeah, I feel like this is also, like, we've kind of morphed into this next question that is about ultrasound.
Do you
just want to tackle that?
Pocus in cardiac arrest, if found to be low flow, is push dose epi with pacing beneficial?
That was, yeah, and I will just defer this because I have not had cardiac ultrasound training yet, so I don't have.
We need Josh from Alert Medic 1 on here. This is his wheelhouse.
Is it? Yeah. Those are, like, a lot of the guys I fly with are big in using ultrasound for undifferentiated hypotension. I feel like this kind of maybe goes along with that question. I just don't have the education yet to answer this one.
Yeah, if they are low flow, then yeah, pressors fluids are going to be useful. Pacing beneficial. I guess it depends on the rate of the heart, or maybe you could capture some of that activity. It makes me think back in the day, showing my age here, when we used to pace asystole with the hopes of capturing something, and we never did. But yeah, I don't really know the answer to that question. Josh and I talked a little bit about it. I don't think there's a good answer yet. I think this is one of those things that people have a lot of thoughts on, but there's not a lot of data out there because people are scared to divert from the whole ACLS AHA algorithms. So I don't know if there's a ton of data on this.
Let's do a couple of fast, easy questions. Rigid stylet versus the bougie. Current discussion with our MD on what he wants us to use. I think it all depends on what kind of laryngoscope you're using. I prefer the bougie over a rigid stylet because that's how I learned. And I have found that however I learn something is usually the way that I prefer throughout the duration of my career, even when things change. But I flew for a service for a short time that used, what was that called? I think it was called the Intabright, but it had a hyperangulated blade, and it's not possible to intubate with a bougie with that hyperangulated blade. And so you have to have that rigid stylet. So my preference is bougie, but if I've got a different laryngoscope, I prefer the rigid stylet. How about you guys?
100%. We train the same way. Is we have the option, we have the McGrath, so we have the ability to use a hyperangulate or standard geometry. At my flight job, we use the GlideScope Go, which you have the ability to do hyperangulated or also standard geometry. And hyperangulated and a bougie in any market or whatever the make is a bad thing. You could have a beautiful view of the glottic opening on your screen with a hyperangulated blade, and your bougie is not hyperangulated. It will not get the same view, and you'll spend too much time poking around underneath it, like a whole Elaine Bromley replay thing. So piggyback on what you said, I completely agree. Your rigid stylet versus your bougie is going to depend on what you're holding in your left hand.
Agreed.
Give them all the tools. Give them both.
Yeah.
That's what we have here. Play around, train.
Yeah, absolutely.
Yeah. I don't think this. You will use this. You will use. No.
I'll stand by. You will use a rigid stylet with a hyperangulated.
Or you're not getting it.
Or you're not getting it. Right? That is something I will stand by. That's a hill I would die on, actually. And unfortunately, some of the mannequins that we have, you can use a hyperangulated and a bougie and obtain that view or get the tube through. But man, on a patient, those two do not mix together. But I guess to your point, Mike, you do have both blades, so you can switch back and forth between the two and have the ability to use either one.
I personally have I've always been a team bougie guy, but I used a rigid stylet on an RSI we did on flight a few months ago. And I only used it because it was hanging out of the bag. And I was like, oh, let me give this a try. And I really liked it. And I've been using it ever since.
I have switched as well. I thought, the bougie was like how Gwenny said, it's what I was trained on. It worked really well. Once we switched to the McGrath, or once I got educated on the GlideScope Go with the hyperangulated, that rigid stylet is just phenomenal.
Yeah. And it is important to train on both if you're going to have the approach of changing. Now, Crunch, that was probably really easy for you to grab the rigid stylet, despite having always preferred the bougie. But because you have so much Airway experience, or experiences, as Wes showed us, but the approach is not the same. I don't want people thinking they can hold it the same. Whereas a bougie, I'm real close to the mouth, threading it in. Whereas that rigid stylet, you're holding it way up here to keep your thumb on the top, and kind of steering it with that. So it's totally different. And if you're going to be open to trying both in the field, don't wait until you're in the middle of a what hitting the fan to try to work that.
Yeah, absolutely. There was a couple questions, maybe even 3 questions on hyperkalemia.
Yeah, there were a lot. I think it's because I've seen so many reels on it lately. It was probably fresh on everybody's mind.
Yeah.
It seems so, and to the point of one of the other questions is like the little bit of rivalry between Instagram accounts or social media accounts. It's like once one person posts it, the next person posts it, and it kind of just rolls around for a bit. But I think it's a good topic.
Yeah, Army EM Doc, he posted a thing about how there was this meta-analysis published recently that showed that calcium, among other things, is not effective for the treatment of hyperkalemia. Now, granted, that was just in the meta-analysis. Now, that whole meta-analysis was kind of like nothing was really shown to be effective in hyperkalemia, like all the stuff like calcium, bicarb, albuterol. Interestingly, they kind of were supportive of albuterol in it, but the crew who conducted the meta-analysis, they didn't seem to have an agenda. It's not like they were saying one way or the other. They kind of put it out there. Hey, here's the studies and here's what we extrapolate from the studies. Some of the studies, though, were not that good. They were kind of low quality. So is it generalizable? I don't know.
I don't think that it's new information, right? We've known that calcium doesn't fix the hyperkalemia. It just stabilizes the cardiac membranes. Two separate things.
Yeah, well, they were saying that calcium does not have any beneficial cardiac effect.
Oh, okay.
That's what they were saying. But what Wes is saying is calcium does not affect the potassium level. You give calcium to someone who's hyperkalemic to theoretically stabilize the cardiac membrane and protect it from the effects of the hyperkalemia. And this meta-analysis kind of showed like, that may be true, but in the population of patients, which was kind of a shitty population of patients, it was not really effective. But looking into some of the studies, because when you read a meta-analysis, you have to look at the studies and then you got to go read those studies. And some of them, what I got from reading it was that some of these were in hospital codes where they go and they check on them on the med surg floor. It's like, oh, we checked on them 20 minutes ago and they were awake. Now they're dead. Start CPR. All right. Oh, we think they're hyperkalemic. Give them calcium and nothing happened. I mean, shocking to no one.
Right.
I don't think they were necessarily the patient who tells you I'm a diabetic or I skipped dialysis because I was on a crack binge for 3 days. So I missed my dialysis treatment and now I've got a sine wave at a rate of 20. Yeah, certainly those may benefit more from calcium administration than your cardiac arrest patient who you're throwing that Hail Mary pass, pushing calcium.
Yeah, so I think, to quote the question, it was, when do you pull the trigger on hyperkalemia? Any specific threshold that you look for? And I think Mike says this at the beginning of every episode, is you have to look at your protocols. The protocol should outline what your threshold is for treatment of hyperkalemia. In the same state where I work 2 different places, it's 2 different thresholds. One is just clinical presentation, and if you see EKG changes, and the other is do an ISTAT and pick the number and treat the number, whether it's above 6.5 or above 5 or whatever. So that was my thought process on it.
Make sure you're documenting your evidentiary support for why you chose to intervene or not to intervene, though.
Very
Sorry,
valid,
my phone or my laptop keeps dinging.
What I have developed in my practice, because it's kind of vague in the protocols, is that I require 2 points to tell me that the patient is hyperkalemic, whether it is wide QRS and a history of renal failure or something that makes me think they're hyperkalemic. If I see 2 clinical findings that point me to hyperkalemia and it makes sense with what's going on, then I'll give them calcium. If they're bordering unstable-ish, if I think they're just hyperkalemic and they're sitting up talking to me with a decent blood pressure, then no, I'm not pushing calcium. But if they're unstable and I have 2 things that are pointing to hyperkalemia, then I'll treat them for it.
I can't get my computer to stop dinging. I'm really sorry.
Don't worry. It happened to me on the podcast a couple times ago. You're good.
Stop.
So to piggyback on that, Jared, this one's not about you if you're listening, but are you picking calcium chloride or calcium gluconate?
Somebody asked that.
Exactly.
It's what you're carrying. It's what's available based on shortages, right? This one's a pretty easy one to answer. Calcium chloride is it has 3 to 4 times more elemental calcium than our calcium gluconate. But as we know, it's more caustic to the veins. You need to be giving it in a large IV, like a 16 EJ or a central line, versus giving calcium gluconate peripherally. That one's, I feel like, pretty easy.
Yeah, my answer to that is whatever you carry.
Yeah.
Same thing. And all the services I've ever worked for, minus my flight job, just carry calcium chloride. So we mix it in a 100 ml bag and give it slowly and monitor that IV. I talked to one of my medical directors today, and he said he'll only push calcium chloride in the central line. So everyone's kind of got their own little thought process to it. But I think whatever you have and whatever your protocol says.
All right, let's move on from the hyperkalemia thing. Do you think that every patient should get an EKG? No.
No, not at all. But if it crosses your mind, they probably should. I would rather over.
I have adopted that, Gwenny. You have made a difference in patient care with me because you said that years ago to me that if the words EKG crosses your mind, you should probably do one. And I will do that in the field. I'll think this patient's freaking fine. And then I'll hear you in my ear going, if the letters EKG cross your mind, you should probably do one. I'm like, you know what? I should probably do an EKG before I turf this patient to the BLS crew.
Because what's the only thing that stops us from doing one?
Having to call med control in Pennsylvania to release a patient if you do one. We need to change that because it promotes paramedics not doing 12 leads.
That's a really good point. Do they have a suggestion box on their website for you to put that in? They do.
I submitted it for the recent protocol update, and I heard from somebody else who's in the know that it is seriously being considered.
Yeah, it should be.
Because you call. So let's say Gwenny, let's say your daughter has a syncopal episode. Let's say she gets into a fight at school and she has a syncopal episode. Your daughter's 13, right? 14?
14.
What do you automatically think? All right, it's a panic attack. It's psychosomatic. Well, there is a chance that she could have long QT syndrome or Brugada syndrome, and you don't want to miss that. But in Pennsylvania, if I want to get a refusal or release a patient who is fine, and I've done a 12-lead EKG on a stable, vague patient like that, there is a solid chance that the doctor who knows nothing, there are plenty of med control doctors who are phenomenal, but there are some who frankly have no freaking business answering the phone and giving orders to paramedics. You get one and they answer the phone and they say, oh no, you can't release that patient. You need to keep them on the cardiac monitor, even though they're going to the freaking waiting room when they get to the ER. Now you're out of service for an hour and a half doing this round trip with this patient. You get paramedics in Pennsylvania, they're going, you know what? Fuck it. I am not doing a 12-lead because I'm going to have to call, and Dr. L over at the county hospital is on duty, and she's never going to let me release this patient. I know that makes us sound lazy, but that is just a fact. That's my soapbox. And I know people in Pennsylvania listen to this. So that's why I'm being so outspoken about this. You want better assessments pre-hospital? Take out the med command requirement for releases.
I like
but Wes, does every patient need an EKG?
No, not whatsoever. I think that your point of if you think EKG, do it. And I think there's also something to be said about the new, paramedic that is pretty confident this is not a cardiac issue. You should prove yourself correct by checking them out on the monitor as part of a learning process.
100%. Yeah. All right, next question.
Oh, I didn't have one picked out yet. Let's do a really easy one. What duty boots do you use?
And whenever you guys want to tap out, just let me know.
I'm good to keep going. What boots do you wear? I recently, maybe 6 months ago, started wearing the OnCloud boots. Total game changer. I don't like big, fat, heavy boots. I don't do steel toes. I mean, I'm not getting in any kind of tactical situation where I work, and I really like the OnCloud boots. They're expensive, but they're worth it.
Cameron, my partner, got them. People met her on the podcast with Ashlyn, and she got them because Ashlyn has them and recommended them. And Cameron is not in love with them.
Really?
Yeah.
I like them a lot. I used to do the Under Armour, like tennis shoe boots, and man, those killed my arch. Like when I walked, I've never had like arch support problems, but those just murdered my feet and my back. And the On Clouds do much better.
I just wear, when I'm flying, I wear like 10-inch Merrells, and then when I'm at my fire job, I have just Red Wings leather that are not comfortable. My deputy chief calls them foot jail because they're just uncomfortable and heavy. But yeah.
I wear the Bates paratrooper boots. That's what my department got me years ago when they supplied the boots when I started, and I like them. I think they look sharp. There's a lot of support. I've worn them ever since, and people make fun of me because they tell me I look like a hooker because they like come up to here. And then I really freak people out because I pull my pant leg up and they see my garter belt because I wear the garter belts to keep your shirt looking tucked in.
Nice.
So yeah, I got my leather fuck me boots and my garter belt.
That's beautiful.
Yeah.
I'm gonna go bleach my eyeballs now after.
I'll send you a picture tonight when I go to
You
work.
don't. I'm gonna block you for the rest of the night.
Mhm.
What qualities do you want in a partner on the helicopter, and is it different than the ambulance?
No, it's not different at all.
Nope.
What qualities are you looking for?
I want humility and somebody that is open to having a conversation. The other day we were doing some flights and we had a couple of electrical things that were going on. Our other helicopter had a mechanical failure. It was getting a part replaced, and we're hovering, waiting to hear from ATC. And he just says, "There's a lot of weird stuff going on today." And it was the day that all the planets were aligning. And him saying that was like, all right, I've noticed that too. Like, we need to slow down. Let's make every decision very methodically. Not that we don't normally, but let's take an extra look at every single thing today. And that's what I want. I want someone who can be open about what they're feeling, and not in a touchy-feel way, but just saying like, something here is fucked up. What, am I the only one here thinking this? But other than that, yeah, there's no difference between air and ground.
I want humility also, but I also want somebody who has some cojones. And that's not a male or like, I don't care, male or female, I don't care. My partner Cam, who I love working with, she's great, female. But I want somebody with some freaking cojones who is not going to panic and make a decision. And I'm not saying this about anybody I work with now. So flight team people, I'm not talking about you, but at my past job, and I'm sorry to say this about nurses, come at me, I worked with a fair amount of flight nurses who were incapable of making a decision without 275,000 points of data and asking the doctor.
Because that's how nurses are raised, right? I'm not defending that behavior. That was the most difficult part for me from transitioning from being a hospital nurse to flying on the helicopter was the autonomy. I was not used to the autonomy, and it took me a long time to make a decision. And sometimes we don't have a long time to make a decision. And thankfully, I've had some really good partners and mentors that have taught me to trust myself and make a decision. I had a really rough flight, I don't know, maybe 3 weeks ago. Then my partner is fresh off orientation. He's a phenomenal paramedic, but very young, not a ton of experience, and new off orientation. So I was definitely the stronger and kind of the leader of and I made a decision really fast. And later when I was kind of debriefing it with myself, thinking, what could I have done better? What should I have done differently? And looking at what I had done, I was like, damn, I made that decision like really quickly, and it was a really big decision. So it's difficult for nurses because we're taught to do these care plans where we bring in 500 pieces of data and put it together to make these care plans. And then we got to make a committee about it, right? And then we got to have 72 meetings about it, and before we can ever make a freaking decision. And that's where I love paramedics. And I think they're the really stronger part of the partnership of the nurse medic dynamic is that medics are the faster decision makers. And I love you guys for that.
That's why the combination works well, because you sometimes need that one person, the nurse, not in all circumstances, sometimes need the medic standing behind them like, okay, make a freaking decision, let's go. And then just as often, that medic sometimes need that nurse to be like, hey, let's not be a bull in a china shop with every decision we make. Like, let's slow down. and consider these things. So both things are true and both things
Yeah.
are equally important.
Absolutely. And just like the reason the combination works so well is this the same partner the other day, we were taking a liver failure patient out of a hospital and he was on CVVH and he had a trialysis catheter in. I was like, what the hell is that? And he took 5 or 6 minutes and educated me on what a trialysis catheter is. It's like, I've never seen that before. He's like, it's a nurse thing. Don't worry about it. But
Yeah.
we both bring our experiences together and it works out very well. I'll do one more and then I got dinner on the table.
All right. We'll do yours. And then I got one for Gwenny about the content creator thing. So if you need to peace out after that, then go do it.
I didn't actually have one. I was just thinking, all right, here's one. Methods you've learned over the years to pull information out of patients. I was listening to Ginger Locke. This is probably a month or two ago. I don't know. It was Rethinking AFib. And she was talking about when we document or we say or we pass on that the patient is a poor historian. She's like, when you look at the word historian, the historian is the one that is gathering the information. The patient is not gathering information to give it to you, or the family member is not gathering it to give to you. You're getting it from them. So stop using that term and ask the yes or no questions. Don't ask leading questions. Be direct about them. Just because they haven't been to the doctor recently doesn't mean they've been to the doctor at all. Or, you know what I mean? Like, how we ask questions changes what we get for answers. And it does take a methodical approach.
Yeah. Open-ended questions all day.
Yep.
Let the patient talk.
Yeah.
Yeah, I have found that you got to be a little bit of a detective, and sometimes you do have to play the part of the friend of the patient, which you always want to establish rapport. But sometimes I will play into a patient's sympathies a little bit more heavily if I'm kind of getting the vibe from them that that's what they need. Like, do a quick assessment of the patient. You know, like in nursing school, when we're talking about patient education, it's assess their knowledge first before I start teaching them, because I might be talking about things they already know about, right? I find the same is true of an assessment. Get to know the patient a little bit and figure out, like, okay, what are their needs? And if it's someone who needs me to be a little bit more mom-like with them, or if it's somebody who's cut and dry and wants to, they know what they want to tell me right out the gate. And then one question I always wrap up my patient assessment with when I'm in the emergency department, I'll ask them, you know, if they're here for an extremity injury. Okay, how long has it hurt? What happened? Was there trauma? You know, assessing it. But then I always at the end say, is there anything else that you think is important for me to know today? And it's the more years I ask that question, the more it solidifies the need for that question. Because sometimes it's like, you know, my hand is on the door and I'm fixing to go out and the patient will go, yeah, there's this one thing. And
I'm
it totally
fixing
changes.
to go out. You are from the Midwest.
I like that. I'm going to start using that, Gwenny.
Is there anything else important you think I should know today? It's really a great assessment tool, and you get some little pearls that I would never have thought to ask someone.
I love that.
All right. Well, Wes, if you got to bounce out and go to dinner, I got one more question.
Yeah, I'm going to go eat some food.
Yeah, thank you for joining us.
Wes, it was so nice to meet you.
Nice to meet you too.
All right. See you, buddy.
See ya. Bye.
All right, Gwenny. We'll finish with this. Where is it? Oh, come on.
I bet I know what question you're talking about.
Yeah, you know damn well what it is.
The top of the second page.
What's the deal with the beef between EMS content creators lately? Is there a war brewing?
I saw that question and I wondered if there's something that I'm not up to speed on. I am not aware of any kind of beef between people, and there must be some tea that I missed, but I'm actually not interested in the tea.
Same. I don't get involved.
Yeah. No, I think there's a tremendous amount of respect across there's a bunch. There's so many. And sometimes I'll be like, how have I not known this person existed? Like, there was a long time where I thought that paramedic Sophie and the bossy paramedic girl were the same person, and they just had two different names, one for Instagram and one's for TikTok.
And two different faces.
I wasn't watching that closely. So people, like some of my coworkers, sometimes they'll be like, hey, do you know so-and-so? Do you watch their videos? And I'm like, the more I put on social media, the less time I spend on social media. I don't doom scroll anymore. I watch very little of other people's content.
Same.
Just because like it's just too much. And I have found that I really enjoy being present where I physically am at home with my family, or when I'm at work, being physically present there. as opposed to being present online, which probably sounds really hypocritical because our success as EMS content creators on social media relies on people that do spend time on social media. But I have a tremendous amount of respect for so many people, and I have learned a lot of things from other creators. Some of the creators have become some really close friends. You're one of my closest friends, and we met because we found each other on Instagram. Jimmy Apple is a close friend of mine. And I think it takes some maturity and some humility to get to the level that we are at as creators, and enough self-awareness that it's okay that we don't all think alike. You're someone who challenges me a lot. Like, there have been a lot of times where you've said some really hard things that were difficult to hear, but you were right. They were hard to hear because you were right. Jimmy is the same way. We challenge each other. I was on a podcast recently, and he called me and was like, I really did not like your take on this. And I had to think to myself, like, hey, did I mess this up? But yeah, no, I have a lot of respect for other creators. I really respect Salim Razai, Critical Care Now, Hani Malamet. He's fantastic. I mean, there's so many great creators out there, and I would much rather spend time talking about what I am for as opposed to what I'm against. So I don't follow any of the kind of negative accounts that just exist to trash other people. I just don't have that kind of bandwidth for garbage. So
I don't get involved. I try to stay out of any drama that is going on, but I do I appreciate a good offensive biting meme. There's no doubt about that. And I do doom scroll, but I'm like you. I don't really watch a whole lot of EMS content. I'll occasionally listen to a podcast if it sounds like something that's interesting to me. But yeah, I get, like, Josh is like all the time, did you hear this podcast? Did you hear this? Did you see this? I'm like, no. Like, my time on social media is looking at pictures of, like, Sydney Sweeney jumping up and down. And then I spent probably 45 minutes last night watching those wholesome ass reels made by that autistic guy who loves trains. He films trains that are coming by him, and he also has the camera on himself, and he's like giddy with joy when the train comes past. It's just, it's the most wholesome thing in the world, but it's also hilarious. So
so I have a personal Instagram separate from my Nurse Gwenny account. You guys can come in. It's all right. My kids just got home. Mine is all workouts, recipes, and dog videos. You want to come say hi? It's your friend. Oh, hi, Crunch. This is my middle one for everybody who watches my Nurse Gwenny stuff. This is the one that helped me make the funny reel that we did a couple of weeks ago. And thank you to everybody who Venmo'd her $1 for her part in the video. You want to tell them all thank you?
Thank you so much.
All right, I'll be done in a few minutes.
All right. Well, on that note, I think, well, it's dinner time here. So
all right.
Thanks for coming on.
I feel like I've spent the last 2 days with you after editing all this video. It turned out really, really good.
Let me stop this real quick. Hold on.